Okay, it's now time for People Helping People, and this month, as we promised, we're going to focus on cancers. Today, we are definitely going to narrow in on breast cancer and cervical cancer. And of course, joining us again for the second time is Dr. Thompson. Good morning, Dr. Thompson. How are you?
Hi, good morning, Ms. Johnson. I'm fine, thank you.
Great. Nice to have you here with us once again.
It's good to be back.
Lovely. So we're going to head into the topic hard on, right? Cancers last week, if you were listening, of course, you would have defined for us, Dr. Thompson, cancer, the rogue cell and etc., etc. That was really good. I really appreciated that, and I know our listeners appreciated that as well. Today, as we said, we're going to talk about breast cancer. This is a hot topic. This is a hot topic for us women, So ideally, I would want to ask the first question.
Sure.
What do I do, or what does a woman do, or a young lady do if she wakes up and she has a lump?
Oh, well, the first thing you have to remember is that not all lumps are going to be cancerous. What we have to do is figure out which ones are cancer and which ones are what we call benign. So that process starts with a history and an examination. So you go to your doctor if you found a lump, or you can go to your district nurse, and they can do what we call a clinical assessment. So they will ask you some questions, see how much of a risk you sound, and then they're going to examine the breast, and based on the examination features of the lump, that's the first step of assessment. The second step of assessment is going to require that we get some imaging done on this lump. And breast imaging, the basic breast imaging, is either going to be a breast ultrasound or something called a mammogram. A mammogram is just a fancy type of x-ray that takes pictures of your breast. After we get that, if those two suggest that this lump is something to be worried about, then the third thing we're going to want to do to answer the question of is this lump cancer or not, we're going to want to get tissue from the lump. And that requires either A, we take the lump out totally, or B, we put a needle into the lump and take some cells out of it. And then we test that under the microscope. We take a look at it. The pathologist takes a look at it and tells us if the cells in this lump look cancerous or not. And that's how we figure out whether the lump is going to be malignant or benign.
Okay, that sounds like a really lengthy process. Let's say if God forbids, a woman wakes up and there's a lump, and the thing is she probably didn't notice it for some months or whatever, and she's at a stage where it's really bad. Won't this lengthen the process or lengthen the time in which this lump exists in her breast?
Fair question, Miss Johnson. Here's the problem. Once upon a time, the doctrine was all breast lumps should come out. What that led to was a lot of women with scars on their breasts that had benign lumps that were taken out.
Understood.
The trick now, or the move now, is to do less procedures or fewer procedures, less invasive procedures,
yes,
and try to get as good a gauge of this lump before any operation is planned or contemplated.
Okay.
So we sort of trap, but I agree with you, we do have to get this process done quickly because time is of the essence.
Most definitely.
Now, what happens though, a lot of times if you come in and the lump is already fairly advanced, it's big and it looks like it feels like it, we may just jump straight to biopsy.
Okay.
Yeah, get the tissue first and confirm.
So, I know breasts, because I have a pair, they have existing lumps, as you would have indicated before. How does one differentiate the difference, or differentiate the type of lumps rather?
Okay, well, as a doctor,
as a regular person, of course.
Okay, now the key to the entire thing is familiarity with your breast. Those are your breasts. You should examine them yourself and get to know them. And if anything seems out of the ordinary, then that's a red flag. Now, where it begins, all examination begins with inspection. You look at them. Sometimes if there's a tumor in the breast, the tumor itself will be attached to the skin and to the chest wall on the inside. And what will happen is that if you move your hands, you will find that it causes the breast to dimple. Sometimes a woman looking at her breast will notice that one nipple is pulled in, or it was pointing the same direction as the other nipple, but now it's deviated to one side. That happens when, for instance, the tumor is what we call tethering and pulling on structures. So all those signs, sometimes there's another feature on looking that looks like the skin of an orange or an orange peel. You know, you see a lot of fine pores in the skin.
Right.
And that itself can be a suggestion that something is wrong. So the first thing you do is you look at your breast. You look for symmetry, you look at the nipples, you look for any dimpling. The second thing you do is that you feel your breast, and you feel it with the flat of the four fingers of your hand, and you make sure that you go in a system. You can either go around the clock, right? Start at 12 and work your way around, right? Or you can go in a square pattern. Start high up by your collarbone, go from the inside, go straight to the outside, come down a bit, go across again, come down a bit. The idea is that you want to examine the entire thing. The other thing that you have to remember is that you have to examine into your armpit.
Right.
Yeah, because the tail of the breast actually extends toward the armpit.
Okay.
Yeah.
Yes. You have me visualizing this entire thing here. Okay.
Now, when your doctor examines it or your nurse examines it, what we're looking for is, can I feel a smooth surface and a well-defined edge? Well-defined edges tend to suggest that a lump is benign, right? Can I move this lump around freely? Cancerous lumps tend to attach to the surface or to the underlying chest muscle. Yeah.
Right.
So if it can't move, then that's a bad sign. Yeah.
Right.
The other thing that we check often, or we check for, is there any discharge from the nipple? Now, if there's a discharge from the nipple, a bloody nipple discharge with blood in it, right, tends to be more of a red flag. Yeah. But the most important thing, just to say it again, be familiar with your breast. Examine them regularly, and if anything pops up, don't wait to see what will happen. Take it to the doctor or to your nurse and get it checked out.
Right.
Yeah.
Okay, I could just even imagine some women right now just thinking about this and probably running to the washroom or lying down or trying to figure this thing out. But I don't want you to panic, right? This is a information drive, people helping people. So we just want you to learn, and as Dr. Thompson would have said last week, it's not the end of your life. All right? Correct? That's
correct.
Right, good.
It's not
so
the end
you
of
have
your
to
life.
back me up here. We don't want anybody panicking.
And the earlier we get moving, the better your chances. That's entirely what the game is about. Early intervention saves lives.
So I do not have to take off my breast, or you do not have to take off your breast, of course, if there's a cancer in it. So tell us a little bit about that procedure, or I wonder if I want to get into that. Probably yes. Let's talk about it a little bit.
How we've thought about breast cancer has really changed from the early 1900s to present time. Once upon a time, again, I'm always telling stories, people believed that breast cancer spread directly. So for instance, if it started in your breast, it would grow and get bigger and then spread to under the arm.
Right.
So the idea was that if we took it off and took off as much tissue around it as possible, then we would have contained it. At that point in the early 1900s, nobody understood the idea of micrometastases, that small clusters of tumor cells could get out of the original tumor and travel through the bloodstream or through the lymphatics to parts unknown. So what would happen, there was something called a radical mastectomy or a Halsted mastectomy, named after the surgeon. And basically what it did was it took off the breast, it took off the muscle, it took off the tissue in the underarm, and it basically left women unable to use their arm. And what was found and what changed how we thought about it was that it was found that those women, maybe they didn't get a recurrence of the cancer on the chest wall, but they still died afterwards.
Wow.
Because of tumors deposits showing up in the liver, or what we
Right.
call metastases.
Right.
And then we realized that it was entirely possible to do more limited surgery and still achieve the same survival. So right now, the options you have, you can still do a mastectomy, but it's not, most times it's not a radical mastectomy. You can do what we call a lumpectomy, where you take out the lump and you try to get a ring or rim of 1 centimeter tumor-free tissue around the lump. Now, of course, the suitability of that as an option depends on the size of the lump relative to the size of the breast. So if, for instance, you have an A-cup breast and you have a 5 centimeter lump,
Wow.
by the time we take that out plus a rim of tissue
Yeah.
around, we've practically taken off your entire breast.
Yes.
Yeah. The other good news, though, is that after mastectomy, breast reconstruction is possible.
That's what I was now going to ask you. Thankfully for that, that's why you take tissues off of the other parts of your body or something
Yeah.
to that extent?
You can take tissue from other areas. You can do a muscle flap, where basically you can take different muscles and swing it into the position of the breast. Or you can even go a step further and get a more cosmetically appealing result
Right.
by just doing implants.
Right.
Yeah, and that those procedures are available in Trinidad and Tobago.
Well, that is good news. But even as you talk about this reconstructive surgery, I always want to know. I know it's the muscle of my body or whoever's body. It's coming from the person's body, right? But I wanted to know, by putting the muscle in the breast area, how does it work? Have you ever had any comments from persons that might have gone through this and they said, well, my breasts feel normal, or how does it feel?
To be honest,
yeah.
it's not the same. It's not quite the same as how your breast would feel.
Right.
When you put on your clothes and you're walking down the road, no one can tell that you've lost your breast, and that's sort of the aim.
That's the aim.
Right?
Okay.
But if you really want to get a cosmetically pleasing breast, then what you're looking at is implants rather than flaps.
Okay, but of course the women probably can't use their breasts anymore for the reproductive purposes, of course, breast milk and all of these things.
Correct.
Okay, but that's a downside. Thankfully, of course, you're still alive. What else do I want to talk about with regards to breast cancer?
I want to go back to something.
Sure.
I want to go back to that little point in history when we realized that even after the radical surgery, that women were still dying from metastases, because that sort of changed how we thought about breast cancer. Now, if I had to describe the thought process, you sort of think of the person as having two problems. There's a tumor in the breast and whether it will recur on the chest wall, and we have to address that. And then there's a risk of the tumor spreading to the other organs. Now, that risk is something we try to predict based on certain features. We predict it based on the size of the tumor,
Right.
whether the glands under the arm, or what we call the lymph nodes, had any tumor deposits in them. Yeah. And then we use special markers on the cell surface that tell us a little bit about the aggressiveness of the breast cancer. We even use a sort of scoring system based on how ugly the cells are to tell us how aggressive this tumor is going to behave. And then based on that, we realize, well, this person has a high risk of the cancer spreading to other areas, or this person has a lower risk. And then based on that suggestion, or based on that assessment, there's a suggestion of whether the person needs chemotherapy after surgery or not. A lot of times we can actually lower the chances of a woman having a relapse of a breast cancer by using appropriate chemotherapy, or what we call hormonal therapy.
Tell me about hormonal therapy. It's the first time I'm hearing about it.
Okay, good question. Now, remember, cancer is your body. It's gone rogue, but
Yes.
sometimes it doesn't go all the way.
Right.
So normal breast cells respond to estrogen, the female hormone. Some breast cancer cells are still fed or stimulated to grow by estrogen.
Okay.
So one way to fight them, those cancer cells, is to reduce the woman's estrogen levels. Yeah. Or to use a drug that blocks her body's natural estrogen.
Right. Okay.
Yeah. And that's how you may have heard the name of a drug called tamoxifen.
No, actually I
right.
haven't, right?
A long time ago when I was graduating from medical school, tamoxifen was the best thing since sliced bread. And it really has made things a lot better for a lot of women who are what we call estrogen receptor positive.
Okay.
So that's where hormonal therapy comes in.
Understood. Okay, I think we would have covered a lot on breast cancer. Of course, you could send your questions in via email or via text, and we could have Dr. Thompson answer them in next week's program. But we're gonna switch things across to cervical cancer, right? Or did you want to add anything else on breast cancer?
No, we can switch.
Okay, good. Cervical cancer is not as easy, I would say, as knowing when you have breast cancer because there's a lump. How does one detect cervical cancer, Dr. Thompson?
All right. I want to make a statement.
Sure.
No woman should die from cervical cancer. Right? Every time you see a woman that has died from cervical cancer, tell yourself that our health system or our health fraternity has failed. And I'll explain why. There's a simple test that was developed many, many years ago. I think it's like the 1920s or so. Someone will correct me if they have better information. Called a Pap smear.
Oh boy.
And a Pap smear gives a 3-year warning of changes in the cervix that predict the onset of a cervical cancer. I refuse to believe, right, that a simple test that takes 10 minutes, right, that costs maybe tops, it costs $150 in terms of materials and is widely available, that gives me a 3-year warning of something, right? I refuse to believe that I'll lose to that cancer.
Right.
Yeah. How we should detect cervical cancer. Sorry, to answer your question, is how do I know if I have cervical cancer, and how I would ask a different question. How should you find out about cervical cancer? You should find out about cervical cancer by having an abnormal Pap smear.
Right.
And at that point, treatment is basically to just take off piece of your cervix. Yeah? Story done. Simple like that. Right. You should not find out about cervical cancer by having abnormal bleeding. Right? That is one of the hallmark signs or symptoms, where a woman will have loss of blood not associated with her period, but associated with things like intercourse. So what we call post-coital bleeding after sex.
Right.
Yeah. That can be one sign, or what we call intermenstrual bleeding. My period has finished, the next one isn't due as yet, and yet I'm bleeding.
Right.
Yeah. Those are two signs. The other symptom that you see in your older patients, women who have gone through menopause and no longer have a period, and then wake up one morning passing blood. Yeah.
Right.
It's not that the period has returned. Sometimes it's because there's a cancer on the cervix that is bleeding.
That is bleeding.
Yeah, so those are some of the common symptoms. Another common symptom of cervical cancer is what we call a vaginal discharge. And typically what happens if there's a tumor growing in the cervix and there's a lot of dead tissue in the tumor, it becomes a breeding ground for bacteria, and you get this very brown, noxious discharge. Yeah.
Right.
But just to say it again, and I hope I say it at least 100 times in this program, we shouldn't get to that point.
Yes.
Yeah.
Yes. Agreed. Well, you have me here having all kind of visuals, but also you missed one. I would think the human papillomavirus. I think we mentioned that last week where we spoke about that when it gets to a certain stage, the virus itself it turns into cervical cancer or something.
What happens? Human papillomavirus. Now there are many strains of the virus, like all viruses. And there's some viruses that are what we call high-risk strains.
Right.
And if a woman gets infected with a high-risk strain and does not clear it from a system, most HPV infections are cleared, some are not. If the infection becomes chronic, then what happens is that as the virus splices its genetic material with the cervical cell's genetic material, that can trigger malignant change. Yeah.
Right.
So human papillomavirus, now there's actually a vaccine available against certain high-risk strains of human papillomavirus, which just makes my point even stronger. Because not only do we have a test that can give us a 3-year head start, but we also have a vaccine that could prevent us from getting the causative infection in the first place.
And that's available in Trinidad and Tobago?
In Trinidad and Tobago,
Excellent. Excellent.
Yeah.
So cervical cancer could be rectified. You shouldn't get it. So that's what Dr. Thompson is saying.
You shouldn't meet us at a stage where we can't fix it.
Right. So there's hope within that whole topic. Of course, there's hope within this entire topic of cancers, as Dr. Thompson would have echoed last week and is echoing this week. And of course, for the rest of the month, we will continue to echo, there is hope with cancers. We just have to take care of our bodies. And of course, women, Dr. Thompson is saying now, know your body, examine your breasts, know what's going on down there as well. When you see certain things happening, take note of them and go to your doctor. What else can we talk about with regards to cervical cancer? Because you would have told me a lot this morning. I'm sure a lot of other persons would have, you said, wow, this is a lot of information.
It is, I think, another important point to make on cervical cancer stems from how it originates. Human papillomavirus is a sexually transmitted infection.
Right.
So what happens is that you tend to find that women who may have more partners or who may have started intercourse at a younger age, right, tend to be at higher risk, right? A lot of times what happens, the women who do pap smears aren't necessarily the women you want to meet to do pap smears. They fall into low risk groups based on their lifestyle, right? And they're not quite likely to have this problem. Whereas the women who we really need to see, a lot of times our programs don't reach them.
Right.
Yeah. And there's nothing to be ashamed of. It's
Correct.
not one of those judgmental things.
No, it's something that you have to do for yourself as an individual, as a woman. As you grow, certain things do happen, and you have to work with the system to get these things sorted out. Correct. Lovely. Correct. So even as you mentioned that, who would come to take the pap smears? Do we have a certain age limit, or
all right,
how
That's a very good question.
Yeah.
Normally, we're not going to start doing pap smears on women until, let's say, age 22, right? And over. And then we're going to see them every 3 years. Now, different countries have different guidelines as to how often to do a smear. Ideally, or one guideline that you can use is you do the first smear, you do the second one next year, and then once those two are normal, you start coming every 3 years to do your smear. Yeah. The important thing though is that we need everybody doing it.
Yes, yeah. Especially if you're sexually active.
Yeah. Once you're sexually active, after you meet your boyfriend, you should meet a gynecologist and you should have your pap smears done. Yeah.
I like that sequence, Dr. Thompson. Yes, definitely every woman should meet a gynecologist before she meets her boyfriend or husband. All right, so we're coining that one here on People Helping People this morning.
Plug for gynecologists.
A huge plug for gynecologists this morning. And of course, a huge plug for Dr. Thompson, who is so educated and just going free. No paper, no phone, nothing. Just going free off of his mind based on what he has learned. And, I'm really thankful to have you here with us on People Helping People, Dr. Thompson.
It's great to be here.
Lovely. So where are places in Tobago or even Trinidad persons can go to first, of course, get their breast examined? I know we spoke about the clinic and etc. but give us some more specifics where persons can go and get pap smears and to get their breasts examined.
No, I know I just made a statement that you meet your boyfriend and meet your gynecologist. But technically, you don't really need to go to a gynecologist to get a pap smear done. Your family practitioner or your general practitioner can do your pap smear. The family planning clinic across here in Tobago offers a pap smear service. We also have a mobile screening unit that is it's a joint venture between the Trinidad and Tobago Cancer Society and the TRHA. And they offer a mobile service where they go to communities or go to areas and you can get a breast examination and a pap smear done. Yeah. The other place that you can check to get this service is at your nearest health center. So really, it's so widely available, there's no reason not to have it. Yeah.
I agree. So folks, definitely get these things checked out. I also want to encourage you to email us hoperadiott@gmail. Email all your questions, so because Dr. Thompson will be with us next week to answer a lot of the questions. We'll do some questions before we get into the topics. So hoperadiott@gmail, or you can Facebook us at Hope Inspirational. And lastly, if you're on Instagram, of course, Hope H.O.P.E.E_TT. So there are so many mediums. Even now at 4893828, you can text your questions and I'll gather all the questions that you'd like to ask about what we have spoken about thus far, of course, which is cancer, breast cancer, and cervical cancer. All right, so send all your questions and we'll have them answered next week with Dr. Thompson. Of course, God's willing. Let's get the ball rolling on cancers. Let's get some answers out there. Let's resolve things. Let's live. You understand what I'm saying? Also, next week we're gonna talk about prostate and bowel cancer. So definitely get your questions for that as well. Call your husband. We all have bowels, so we need to know what's going on with our bodies. All right, so this is the People Helping People segment and we're focusing on cancer. Dr. Thompson, do you want to leave any encouraging words with us as we close on this topic of cancer, breast cancer, and cervical cancers?
The only thing I would say is that early detection is key. Early detection is what really saves lives. If we get people early enough, we can actually make a huge difference. The people that we can't save are the ones that we meet too late. Yeah.
Okay, great. So that's how we wrap up this week's People Helping People segment. We're gonna head back into some music right now. It's Holding On to Positive Expectations. It's on Pulse 89.5 and it's every Sunday.